There is no investment, not even 100 rupee of investment. All that you got to do is have that feeling, I want the best to my patient.
Any other questions?
Yes.
I think that's a different question totally. I think that can be answered later on. I think we can discuss during the dinner.
I'll quickly give him a short answer. Number one, if you read your PNDT Act, any MD can get an ultrasound machine registered for him. Any MD. It need not be only medicine MD or doing a cardiology. No, any MD. Once you have an ultrasound machine, you can do whatever you want, provided you monitor and check all the things. You have seen, whilst we were doing the workshop, the PNDT people came, checked the machines and went away. They checked the number of the machine, they all came. They will monitor you, but you must be doing the right thing. Problem comes when we do a wrong thing and then these people try and swoop upon you. And then you, in India, you know, then it's just a noise. Don't get scared to put ECG echo machine in your clinic. Don't get scared. You can all of you have a right to ask for a registration for PNDT. You have a right. Show them this. Ask them on what rules and regulation you are telling me I cannot get the machine. Get it written from them, and then we'll take it further. It is artificial. What is happening today, a lot of artificial intelligence, it will keep on growing over the period of, this is just basic. I think this has lots to refine. I remember what we did the program in the 3 years back. We changed the whole thing today. That company is mad after me. I keep on making them change because as a doctor, I've spent time with the engineers to develop the software. And it is all artificial intelligence. I've given my knowledge to them to create it.
That's a real intelligence.
Yes.
That's a real intelligence. Real intelligence, not artificial intelligence. Okay, thank you, Dr.
Okay,
Digambar.
thank you so much.
I'd like to call upon the next speaker, Dr. P.P. Jayagopal. Sir is the Vice President of the Indian College of Cardiology. He's heading the Cardiology Department in Lakshmi Hospital, Palakkad. He's also a luminary speaker amongst the cardiology circle in India. And we're proud to have, privileged to have him amongst us to enlighten us on heart failure registry in India. Over to you, sir.
Respected Chair, good evening, friends. Must be wondering, I mean, going by what was mentioned by the Chair, standing before the spirits, and and also by, I think it's 6:30 Goa time, the emergency physician should be rocking. So, wondering why somebody is coming here and giving a talk on heart failure registry for the emergency physicians. Can I have my first slide, please? So, I must first thank Dr. Chauhan, because this is an area which is very passionate to me in terms of research. And I must confess here that I've been in about 30 years of my practice, and I have run a very busy acute critical care, emergency care, as well as cardiology care. But over the last few years, my interest has slowly gone into the area of research. Next one, please. Can I have the, so the, if you were to look at the admissions these days, there was a time when the STEMIs, you heard a brilliant talk a little earlier, the STEMIs were really in large numbers. But then over the last few years, what we have seen is that there has been a significant increase in heart failure admissions. And in a state like Kerala and also in the rest of the country, I'm sure the major problem with even the aging population is acute heart failure. So again, wondering why I'm giving this talk, because Dr. Chauhan really wanted me to stimulate some sort of research. And I can tell you, though people are all enamored with the gadgets around and we look forward to treating patients in an emergency and we get a lot of thrill out of it, I think an era has come where we need to really document what we are doing, and also to go by, maybe in the years to come, see whether whatever you have done in the previous years is right, or whether you should be taking any further steps to improve your practice. So what seems to be a paradox, the prevalence, incidence and mortality of heart failure is steadily rising despite the dazzling progress in diagnosis. In fact, ECHO has come to help in so many ways in diagnosing heart failure, but unfortunately, the mortality is going up. Heart failure may be considered as the last great battleground of cardiac disease, mentioned none less than Eugene Braunwald. It's a global burden. We all know that 62 million people actually they died because of disease, because of the aging population, risk factors. I'm not going into the details. What is happening in India? It's really an iceberg. Is it a tsunami which is just coming in? 16% of the global population. We all thought that rheumatic heart disease and all these so-called communicable diseases were high. But then I think if you were going by the global burden of disease, last 2 decades, 1990 to 2006, you find that the lifestyle diseases have taken over. And what you see there, the burden is actually shifted down to hypertension and coronary artery disease. And that's why we have a large number of patients with heart failure. So much so, the significant prevalence, the history of myocardial infarction, the annual mortality rate is very high. And we also find one of the major problems is that though you diagnose heart failure and treat these people, they come back to you with recurrence and recurrent hospitalization. And that's where our role of documenting things and the scope of registry really comes in a big way to prevent rehospitalization and to reduce the mortality. You find that as the number of hospitalizations go up, I mean the mortality also keeps climbing. So the main focus will be to reduce hospitalization. That's a need. That's why exactly you need all these data and registries. So how are we handling or gearing up to handle this epidemic of heart failure? What can we do about this? This is actually in the news. We try to compete with China for everything, and we compete there also. You see what is happening there. The deaths 23%, whereas China has just got 7%. So we do not know whether it's a little bit of an underreporting from China, but then the fact remains that we have the world's most heart failure. And mind you, until unless you are very well trained in an emergency department to treat heart failure, I would say any patient who comes to you with dyspnea in the emergency department, first try to do a rapid rule out of acute heart failure, either by an echo, a focused examination, or even a NT-pro BNP as was mentioned earlier. Not only that, in India, the problem, when you try to compare with the global figures, you look at the mortality there, 3.8%, it's 10 times more. Just like myocardial infarction, which comes in 10 years earlier, we also find that the heart failure creeps in much earlier, affects our younger population who are the breadwinners, and then it has a devastating effect in terms of mortality and also the morbidity. The first, international studies, that's also always fashionable. Why did I start this study? Particularly so because we started developing an interest in the registries. In fact, we are very proud that we produced the largest registry in the world on acute coronary syndrome. Close to about 26,000 patients from Kerala, 129 hospitals. It got published in European Heart Journal in 2013. But then we found that, what did we learn out of it? We found that there are a lot of inappropriate thrombolysis. 20% of our patients in Kerala were thrombolized without a reason. Because of this data, we went to the next step. We had the ACS quick registry. We implemented some tools into that and then put some guideline-based modifications to therapy and all that. And we found that just joining a registry actually improved the quality of care. That's a message. When you start running a registry, when you have 50 or 60 hospitals running it, the hospitals start competing with each other. And what did we find? The mortality rates in our centers, the ACS quick registry, which was the follow-up, was done only in 69 hospitals. That again got published in JAMA last year. One again landmark studies. And they found that our mortality is only about 5 or 6% in acute myocardial infarction, which is globally acceptable. Why did this happen? Just because we got enrolled into the registry. The quality improvement took place there itself. So the message is, but what had happened so far is all these registries used to come in. In fact, we got introduced to registry through Salim Yusuf. He had an interest in India, and he's one of the the big man in Canada, Hamilton. Create Registry was the first registry. Likewise, today we have a lot of people coming out from the rest of the world to India, trying to study what is happening in India. You have the International Congestive Heart Registry, which is about 5,800 persons, and they also came out the similar pattern. I'm not going into the details. Much younger, more symptomatic, more often treated with digoxin. Digoxin is out of the world. There is nobody who ever uses digoxin for heart failure today, though it's about 200 years, except in special circumstances. Little education, low rates of health insurance, and so on and so forth. And they also found that Indian patients had lower survival. So all this data actually were coming from the Western population. If you were to look at one country which has got fantastic outcome studies, fantastic in terms of standard of living, whatever measure is Sweden. And what is happening there? Large number of registrations, I mean at least 100,000. Whereas you look at Danish, it's, so the number of people getting enrolled in the registry is indeed a marker for your wellness. In other words, you start getting into registries, into research, you improve your quality overnight. That's a message I want to bring in. So I think as emergency physicians, even if you tackle an emergency situation, document it and then hand it over to somebody who's interested in research so that you do better in the years to come. The first initiative in India came from Trivandrum Heart Failure Registry. It's a very small area in Trivandrum which was studied. Dr. Harikrishnan was the principal investigator. About 1,200 patients which were studied. And again, followed up for a year. Very interesting data. They found that 72% had ischemic heart disease. And this is just the figures. And they found that at the end of 1 year, the hospital rates were, the in-hospital mortality as well as the recurrence is very high. 30%, one third of the patients were really coming back with a recurrent hospitalization, and that's a real burden on the exchequer. So these are the data, but it's a very small thing which came from but this actually generated interest in some of us. The Trivandrum Heart Failure Registry, that's what I again mentioned, 1/3 of heart failure, they die within a year. So it's much more sinister than a myocardial infarction. The moment you have heart failure, you know, you are actually dealing with much sinister problems. And readmissions based on 1 year mortality based on therapy. What they found that if these patients were offered, today we talk about guideline-based medical therapy. For example, ACE inhibitors, beta blockers, mineral corticoreceptor antagonists, and so on and so forth. You keep a checklist on these patients, when, you know, even in an emergency department. See whether you started using this. See whether on discharge with these patients are on that. And if you find these patients are on 4 guideline-based medications, the hospital admissions and mortality rates are much less. The readmission rates are much less. So that is one way you could improve the quality, and that's what essentially we are also trying to look at in our registry. So it goes on to say that if these patients are really on these guideline-based medications, they do well. Again, another registry came in. I'm not again going to the details of that. Just to mention the point that in a country like India, the usage of beta blockers is significantly high, whereas ACE inhibitors or ARBs actually is not all that well. And then again, this is one drug which actually improves survival. And that's where we really started thinking of bringing in. So I was offered that, given the challenge or rather the task of conducting research for ICC, that's how this idea came into me. I thought this is an area which has not been studied anywhere in India. So we actually moved into it. The objective was to document initially the demographics, find out the clinical patterns, just a simple things, how patients were treated, what all medications they were given. This is what we are in various states in India. And the primary outcome was basically look at what percentage of patients die in the hospital, what percentage of patients die at 30 days and at 1 year, and also to look at the rehospitalization rates. And we also had a lot of other information. There are about 160 parameters to be filled in, with the secondary outcome basically to look at the diagnostic and therapeutic options, whether the patients were on these guideline-based medications, whether they were being followed up. I tell you, this is a very challenging task. The initial idea was to enroll at least 10,000 patients from all over the country. You know, we had 4 zones: South Zone, North Zone, East and Northeast together, Central and the West Zone. I must confess that the South Zone is doing well. The plan was to study for this for a year. It's a longitudinal study. We would continue. We are actually funded by the ICC, which is actually looking into the logistics of running this for a longer time. The basic methodology we followed was inviting various groups. I went over, in fact, would have talked to so many people. I've been traveling extensively for this, but then the acceptance is very less. Many people do not want to be involved in research. But I tell you, the sheer pleasure of getting some data, and then if you're able to improve the quality by just entering your data, you would have done wonders for the rest of the country. So I think they could be part of all this by just being methodical, systematic. Ethics committee approval was needed at every center, training through software, and this is basically through an electronic method. This is what it looks like when you go into our website, and then all the things can be easily entered by a person who has some basic knowledge. I'm not again going to the details. And that's how it would look. Once everything is entered, it becomes green, yellow if something is left behind, and then we have been following up very well these patients. Just to give you a brief glimpse of what I've been doing, unfortunately I can't share you all the data right now because we have about 22 centers. That's our website. If somebody is interested, you can really log into that site. Total enrollment as on today is about 3,761. This is the largest ever so far in the country. The one which was in Trivandrum was only 1,200, which is a very small area, but it's the whole of country. Total follow-up, which is perhaps the most important thing, is about close to about 3,118. and it's already about 2,778 completed. That's what our website is like. You'll have all the information there if you really want to log in and see. That's how we actually started it in August in the pilot program, which started in South India there. And then we entered the rest of the country. As you would see, it's very challenging because the rest of India is not like South India. I have no bias against anybody, but then getting people to get involved into this research is extremely tough. I keep talking to them in a busy practice, talking to them, but then the kind of involvement is a lot to be decided, and I think we should all get out of this situation and start doing it voluntarily on our own. So just a brief, because I can't give you some of the data because I am presenting our data in the European heart failure. Its paper has been accepted in Athens this month, 25th. I am presenting our data on 1,300 patients. So this is just a glimpse of 500 people which we studied. We find a high percentage of diabetes and hypertension. Again, the etiology mostly ischemic heart disease. So one message is somebody comes with an acute heart failure, always get an EKG done, rule out an acute myocardial infarction or an acute coronary event. Classification, elderly is more prone, but gender level, again, place of residence, urban, rural, did not make much of a difference. And we were also looking into the hospital stay. An average hospital stay was about 5 days in about majority of the patients. But then there were patients, sick patients who would have stayed longer also in the hospital. And mostly, one important thing in India, this again tells you it's a re-hospital, acute and chronic. Recurrence of hospitalization is perhaps the most common thing. And also because some of our people who designed the study also felt that we must also get a glimpse of who finances that, whether it's a government, whether it's a insurance scheme. So just that's why this data is also there. Kidney disease, 13% of our patients with heart failure have renal disease. It's an aging population. And we've also been trying to trace the amount of people getting on this guideline-based medication. That is what it looks like. Very small percentage. What you need is a high percentage of ACE inhibitor ARB. Lot to be done there. That will actually improve the standards. The in-hospital mortality is close to about 6.4%. And follow-up mortality at 30 days again 6.6, and 30-day rehospitalization is also significantly high. So this is only at the end of the month. It is actually for. So I can't present it because I have some terms and conditions with the ESC heart failure, which obviously I'm presenting the data there, so I can't give you all this information. There are a lot of challenges when you run it. Consecutive enrollment is extremely difficult. Losing enthusiasm by the participating centers. Every other day you need to motivate them, incentivize them to keep them on the track. We are incentivizing them. Data monitoring is very tough. There are people really looking into the task. And of course, we need to do the corrective measures at the same time. So the problem is, as I had mentioned, younger, much younger, more symptomatic in India, little education, low rate of health insurance, more often from the rural areas. Availability of devices and things are not available. Door to fruit time, this has become a very important thing. You talk about sepsis, now in JC accredited hospitals, you must know what time the first antibiotic dosage was given. In an emergency physician, I think that's very important. Likewise, the time spent when you treat a STEMI, it's important, door to balloon time or door to wire time, that's the latest terminology. Similarly, there's something called the door to frusemide time. The first dose of, because there is data to suggest that if you give Lasix sufficiently early, within 1 hour, the mortality rates are low. So that's again very important, and it's important to have the right information. Technology comes in. You heard Dr. Naik speaking about it. How do we use technology? Because essential components, you need the heart failure registries. I'll just come to this in a minute because outcomes in patients with heart failure, there are a lot of studies with the hospital readmissions in the Western population. This is how it is. Basic problem that we see in India is actually dropouts, patient drug compliance. So non-drug adherence, this is actually even the Western statistics, this looks exactly the same in our country also. And there is a lot of cost involved. Hospital visits, emergency department presentation with heart failure from the registries, repeat visits close to about 80%. So the simple story that somebody has already had a heart failure, don't even waste time, comes to a breathlessness, use a furosemide straight away, and that actually may be life-saving for the patient. In fact, this is what I tell patients. If you have a heart failure, always carry an ampule of Lasix and a syringe with you, so that the moment you get this injection, some of them really their lives are saved because of this. So the repeat visits are less. Approximately 80% of ED visits are for heart failure. It results in hospitalization also. So there are a lot of hospital core performance index, complete discharge instruction. This is something which the emergency people can also imbibe in appropriate use of ACE inhibitors at discharge, LVEF evaluated by an echo, smoking cessation, and so on and so forth. There is a big registry, ADAE registry, which is very very popular in terms of the data which has been, and this is also actually, if the treatment has been initiated in the ED, you find the length of hospital stay is considerably less. So I think there is a role for emergency physicians in getting involved in these registries and also in also finding out what their treatment protocols are. And again, history of utilization of evidence-based medicines, which have, this is one of the largest registries. You still see that even in a country like US, all 4 medicines in the appropriate dosage is less than 1%. So there is a long way to go. I think by doing all these registries, you could improve the situation. And you also must understand that even if you pay, however good you are, even if you use a NT-proBNP at discharge, you still find that the symptoms may be improved, asymptomatic of 50%, but this 37% are still symptomatic. So I think it's a large chunk of the population which you need to really follow up. And there has been some other studies also coming up, the Optimized Heart Failure Registry, which is also trying to look out the ways and methods by which integrate your telemedicine into this department and run these registry programs. I must also tell you that it should not just stop with the emergency physicians. I think the nurse practitioners have also got a big role. They have found out that even in a Western country, this is one of the new data where they find that the re-hospital is much higher. And there's a strategy which has been done in Africa. In fact, a very amazing thing that, this is actually nurse-driven clinics in the periphery. And once they got involved, they found that the hospitalization rates have come down drastically. So this is something which we need to follow in all our registries, and also we must also have the paramedical. In fact, I have a nurse who is now trained. They would make the call, try to find out whether the patients are on regular medications, check the weight, and then they schedule all the visits and do that. And this actually translates into less hospitalization. So I've actually participated in the third part, which is this is our ACS Quick. We found in acute myocardial. This is our paper which got published in JAMA last year. I must confess that though this did not really give a lot of benefit, because once you enter into registry, the quality improvement improves. We actually we just finished the ACS Heart Failure Quick Registry, where we tried to see whether if a nurse follows up and whether when you start giving them the emergency room early enough, and then if you discharge these patients and all these appropriate medication, they do well. It's really found to be useful. The data is not yet ready. It may be published in a few months' time. So there's still light ahead for heart failure in India. We have the registry coming up from our side. The Kerala Heart Failure Registry, which was done only in the state of Kerala, about 7,500 enrolled. I think it's already ready for about publications now. National Heart Failure Registry, which is done by the ICMR, they're actually looking at 10,000 patients, 45 centers. So there's still a long way to go. I think it's high time that the emergency physicians also, but your requirements are probably different. Maybe the task force meeting where we could sit in tomorrow and then discuss some of these issues and try to find out a strategy for emergency physician as well. But the only thing I just wanted to convey here is that just don't stop with treating a patient. I think it's important that each one of you will have the kind of research this thing in your mind. You can cultivate that, you can grow on that, and this definitely translates in terms of better care and also better survival for your patient. So this is the first ever National Heart Failure Registry. I'm happy to share it here, multi-centric. But I tell you, when you have to run a registry, there has to be a lot of passion required, and you need a lot of cooperation from the centers. Finally, it all should be there. You should convince yourself that you can do high quality research in your own country. Don't ever look at the Western countries for data. I think it's all within you, large volumes. I think you can always do it on your side. And networking and funding from key players, it's also important. It's also possible, because now I am bombarded with a lot of people contacting me for possible coordination and trying to take this forward in a much better way. Thank you all for the kind attention. So the road to success is always under construction. You could always do that.
Thank you, sir, for the very passionate talk. Questions? The floor is open for questions. Any questions?
I'm sure this would have been a topic of no interest to the emergency physicians, but then,
No, sir, I don't think so.
That means extracorporeal shock myocardial revascularization therapy.
You are talking about
Extracorporeal shock.
ECMO. You are talking about ECMO?
No, ECMO.
Yeah. See, ECMO is basically something to tide over a crisis. I would have used it only once or twice in my practice. Somebody who has a reversible cause, for example, a young patient with myocarditis comes in, you find that the patient has a bad heart and then the lung is equally, and you want to give rest to every organ. This is indeed a good method. But then somebody waiting for a transplant, the family is financially well off, they can sustain the you could possibly start them on an ECMO, stabilize them, put them back on LVAD and these other devices before you subject to transplant. I had one instance where a young guy came with an acute myocardial infarction. That's way before Jayalalitha had it, because after Jayalalitha came in, it became very popular, had this ECMO. So this had an anterior wall MI, did an angioplasty, he was not doing well, multiple supports, ventilator, he was on an IABP. Whatever you do, the heart wouldn't pick up, the lung was bad. We put him on an ECMO, did wonderfully well. First 5 days, he came out, I was able to remove the IABP. Of course, we didn't extubate the cardiac index, everything improved. But the problem with ECMO, you should understand, is to maintain that infection. Second thing, the arterial is a much bigger sort of a cannulas and catheters which go in. So the chance of infection, this patient finally succumbed to sepsis. So that's a sad part, I think. But then in a country like India, if it's an abortable patient, I think reversible cause, always think of an ECMO. I think it has a role. Well, there are two things. One, registry is just getting you're trying to acquire data of whatever you're doing in various hospitals. So there is no clinical drug or anything which is involved in it. And for you to enroll in a registry, all that you need is an ethics committee approval of your center to get an entry into the. There are protocols, set protocols which are formulated for any registry. For example, you want to be part of a acute myocardial. There are certain protocols, like you define everything, the time of your patient coming in, what therapy you have done. So there is a protocol which you accept, which every center would look into it, and then your ethics committee would approve it. Usually this is for a pre-specified period. You really want to study about it's the first step towards finding out what your problem is. Let me put it that way. So you find out that 60% of your patients come to you with acute heart failure because of ischemic heart disease, or let's say 40% are because of hypertension. So this is the data on which you build up your subsequent studies. Like you know that hypertension is a major cause, then you try to see whether treating hypertension prevents heart failure or that improves. So the research part in this is only in terms of publication. This is basically a data on which you can improve your service. But the best part about that